Good afternoon, everyone, and thank you for joining us today for this rules workshop. I am Amelia Boyd, and I am the program manager for the Commission and the organizer for this webinar. This meeting is being recorded and will be made available sometime next week. The documents which will be discussed here today are available in the handout section, excuse me, and on our website, which is wmc.wa.gov. All attendees are muted. Panelists may unmute themselves and share their webcam. Attendees, if you have a question, please use the raise your hand function or use the question section, and we will get to your questions as quickly as possible. So right now I will begin the roll call of panelists and staff. When I call your name, please introduce yourself. So go ahead, Ariel, you're first on my list. Oh, we can't hear you.
Hi, I'm Ariel Page-Landstrom. I'm a supervising staff attorney with the Commission.
And then next up is Heather.
Yeah, hi, I'm Heather Carter. I'm an assistant attorney general, and I am the legal advisor to the Commission.
And then Dr. Domino.
Hello, I'm Karen Domino. I'm a commissioner. I'm an anesthesiologist. I'm a professor at University of Washington in Seattle.
And then Marissa.
Hi, I'm Marissa Courtney. I'm the licensing manager for the Washington Medical Commission.
And then Mike Farrell.
Good afternoon. I'm Mike Farrell. I'm the policy development manager for the commission.
And then Teresa Schimmels.
Good afternoon. My name is Teresa Schimmels. I'm a physician assistant, commissioner on the Washington Medical Commission. I practice dermatology in Spokane, Washington.
And then Jim, go ahead and introduce yourself, and then go ahead and read the script, please.
Oh, sure. Okay. My name is James Anderson. I am a physician assistant, and I'm also a member of the Washington Medical Commission. I practice in addiction medicine in Seattle. And I want to welcome you all. Oh, I'm sorry.
I have a quick
Teresa
question.
Sure.
Yeah, I'm sorry. Amelia, would you zoom in on your slide a little bit and make it a little bit bigger to that page?
Oops.
And then we'll be able to see it just a little bit better.
Is that better?
Oh, it didn't go.
Oh,
It was bigger. It was bigger earlier.
Oh, that's great. There you go. That's it. Perfect. Thank you. Sorry to interrupt you, Jim. Carry on.
That's okay. And again, I'm James Anderson, and I'll be the presiding officer for this rules workshop. Today is Wednesday, April 7th, 2021, and it's now 2:03 p.m. And this meeting is being held via the GoToWebinar platform. The rule being discussed today is regarding Chapter 246-918 of the WAC, which is the Physician Assistant Chapter, as well as Substitute House Bill 2378, which is concerning physician assistants. The pre-proposal rules package was filed in the Washington State Register as number 20-24-015 on November 19th, 2020. As we will now discuss the draft language, beginning with the WAC 246-918-055 practice agreements. Ms. Boyd will now take us through the draft.
And if you can blow that up again. Oh, you are so good. Thank you.
I can't hear Amelia.
So the reason we are dealing with this section first is because it was really the last thing we needed to deal with, and we've gotten a lot of comments about the anesthesia training, and we feel like it needs to go in this section because in the bill it talks about how it has to be on the practice agreement the training that, you know, whatever training that we say they should take in order to practice anesthesia. So we received several comments about this. I sent 2 more. We received one from Wisma yesterday, which was really just in, they're just supporting what we're doing. And then we received one from the Washington Academy of Physician Assistants today, and that one is available in the handouts, and I will go ahead and open it and we can talk about it. But mostly we are going to focus on this section, subsection 3, that we've received some language. I have the language from, I can't remember these initials, it's WANA, I think it's something nurse anesthetist, Washington Association of Nurse Anesthetists maybe, but this is the language that they are suggesting. And then we have this comment from WAPA that goes into some detail about what they would like to see in this part. So really, I'm just opening the floor for you guys to discuss that. And like I said,
I have a
WAPA
comment.
comments in the handouts. Sorry. Yes, we can hear you.
Can I talk? Yeah.
Yeah.
Okay, great. So as an anesthesiologist, I have looked in and studied a little bit about this. I can tell you there are some concerns that I had in an earlier version. Perhaps it's that what's here, and it's that education consistent with an anesthesiologist assistant training. And I think that's not exactly the language that is best. I mean, there is an anesthesiology assistant is not just a standard PA in that they have some special education. And I think one of the things is that, and if you're looking at the CMS conditions for participation for anesthesia services, you don't see a regular PA on this list as being able to provide anesthesia services. You see anesthesiologists, you see DOs or MDs, you see dentists, oral surgeons, you see certified registered nurse anesthetists, and you see anesthesiologist assistant who has to practice under the supervision of an anesthesiologist who is immediately available if needed. And that's often immediately available as part of a big thing and not remote supervision. The other comment I wanted to make is that an anesthesiologist assistant is someone who works under the direction of an anesthesiologist, not under another type of physician who's not an anesthesiologist. And that this person has to be a graduate of a medical school-based anesthesiologist assistant educational program, which our state currently doesn't have. And that they also, in addition, need to be certified by something called, I have here, the Committee of Accreditation of Allied Health Education and Accreditation. And this, I looked up what this was on the internet, and this provides accreditation and certification for a lot of allied health specialists, such as example of sports medicine therapists, people who perform the sleep studies, and a variety of perfusionists who do cardiopulmonary perfusion, bypass perfusion, and a number of other specialties. So I think given those sort of things on a federal level, we have to incorporate that language into this document. I don't have another comment.
I think, so remind me on this, Mike or Jim, was this anesthesia or intrathecal anesthesia training, was this a separate line in the bill?
Yes.
It was. And what does that read?
Let me go find it.
Is it, I mean, is it on here? Is this what is in highlighted in red, number 3 here?
No, I will go pull it from the bill real quick.
I'm trying to get it up on my other page and I'm not having much luck with it.
I
Mary,
do
I'll-
think we came across this language last year over something, and part of it is that if you're providing general anesthesia, you do need to have specialized anesthesia training and certification in that area, and CMS defines who those practitioners are. In terms of intrathecal anesthesia, we in some places will consider all nerve blocks as part of that. However, I think we allowed a little flexibility for our PAs who don't have specialized training as an anesthesiologist assistant to be able to provide a nerve block, such as working in the emergency room and doing something to, a finger block to be able to repair a finger. Whereas neuroaxial block, which are spinal and epidural anesthesia, have a lot of safety issues, and those need to have very specialized anesthesia training.
So here's what the bill says. It's the subsection 3. It just says a physician assistant delivering general anesthesia or intrathecal anesthesia pursuant to a practice agreement with the physician shall show evidence of adequate education and training in the delivery of the type of anesthesia being delivered on his or her practice agreement.
Do you think we need to add evidence of adequate education and training with certification, appropriate certification from whatever the governing body was you were talking about? Karen?
Well, I mean, I think there's already a program for people who are similar to PAs, but not certified as a PA. They're certified as an anesthesiology assistant.
So I think
and that is a separate certification program. And that's what we really need. These people are well trained, and that's
one
important.
of the issues with this is that, and correct me if I'm wrong, Marissa, we don't require more training for any other area in PA practice right now in order
That's
to
correct.
get a PA license. And so
Right.
this would be quite a difference for these PAs to require more education in this area than any other type of PA practice. So this would be quite a change.
Aaron, this is Jimmy Chung. I just wanted to ask you if there are any places or any cases where PAs are actually delivering anesthesia. I mean, the only non-physicians that I know who deliver anesthesia are CRNAs, who are outside the scope of PAs.
There are anesthesiologist assistants in a number of states. I can't remember exactly. It may be 15 states. My understanding is the state of Texas regulates these people under the PAs in the sense that their training is similar but different.
And I'm not aware of any in Washington State that are doing it. Do you know, Marissa?
No, I don't.
So we do have someone with their hand up. So Amy, if you want to introduce yourself.
Sure. Thank you very much. My name is Amy Brackenberry. I represent the Washington State Society of Anesthesiologists. We did submit some language that was included in the meeting packet. It's very similar to what is proposed here related to anesthesiologist assistant training, except for we suggested putting it in the under the PA licensure, and now seeing, obviously, because it's referenced under the practice agreement section of the legislation, it makes sense to put it here, and I totally get that. Some of the questions that you've asked, there are 17 states that currently license and regulate anesthesiologist assistants. 2 of them do it through the delegatory authority, and the other 15 have like an explicit statutory reference for anesthesiologist assistants. And I guess I had a question initially about Dr. Domino, what you were saying about the language that is proposed here. It's, are you saying that you are in support of what is being proposed here, or do you think it needs to be different? Because I know there are comments from the nurse anesthetists and the PAs. So 3 different provider groups have proposed 3 different ways to address this, which is, you know, probably not all that surprising. But I just was first, I guess, hoping to clarify Dr. Domino.
So what the document I'm looking at, which frankly I just can't see well enough on the one that's up on the screen. Under 3, it says, it must be noted in the practice agreement that a physician assistant delivering general anesthesia or intrathecal anesthesia has had training that is consistent with the certified anesthesiologist assistant training. I'm concerned when someone says it's consistent with that. That is not exactly, I think, what would be safest for our patients. I think it's those who have demonstrated, it's who are certified as an anesthesiologist assistant, and meaning that they've gone through the training and they are also certified by a national regulatory body that gives them a test in this area, and they have a standard curriculum. And that's what I would like to see more explicit language, because consistent is nebulous, and it's, I don't think we want that. I don't think that is good for safety.
Okay, good. Thank you for clarifying that, and that makes sense. And I think that's our position too.
Could I ask, what are the ramifications of, I think it was the CMS listing people who could provide this service and it not including PAs? Does that have, I mean, what are the ramifications of that to us, if any?
Well,
I don't know who you're asking, but I can only say I just have something, which is the list about these. Since we, you know, anesthesia services, the anesthesiologists do provide anesthesia services and have that. So it's just something that I knew about. Maybe someone is better versed in this than I.
Well, this is Amy again. I don't know. So my understanding is that the CMS regulation that Dr. Domino is referring to is for hospitals and surgery centers. So what that means is a PA could not be reimbursed for administering anesthesia by CMS because it's not recognized. So it doesn't speak to office-based services, and I don't know if there is a separate CMS regulation for office-based services, but yeah, they would not be they could not be reimbursed by CMS for administering anesthesia because it's not recognized.
Thank you.
So we do have one other person with their hand up, Melissa Johnson, if you want to go ahead.
Thank you so much. My name is Melissa Johnson, and I represent the Washington Association of Nurse Anesthetists. And I thank you for the opportunity to have this conversation. I just want to point out that the anesthesiologist assistant training is for a provider who is going to be supervised by an anesthesiologist. And of course, PAs have no supervisory requirement here. And so that's why our comment is that if a PA is going to be delivering general or intrathecal anesthesia, and practicing independently, they should be held to the same standards as the other anesthesia providers in Washington who are anesthesiologists and CRNAs.
Just to clarify, thank you. I appreciate that comment. All these comments are very helpful for me. So just to clarify, when you said that PAs, I think you said PAs are not currently required to have supervision? Is that what you said?
Right. I mean, they practice via this practice agreement, but there's no requirement that the physician is on site or writing on chart notes or proving anything. The intent here, I think, is to practice general anesthesia independently, and I think they should be held to the same standard as the other providers who are also practicing without any supervision. General anesthesia is a very serious protocol, as you all know.
Sure. Although I would say it's not my understanding that the purpose of this or any other part of this PA rules is for PAs to practice independently.
They're not supposed to. It's an anesthesiologist assistant is never practices independently. They're supposed to be practicing under a medical direction model where someone is immediately, an anesthesiologist is immediately available.
Yeah.
So it is different than perhaps some PAs. But it is because it's very direct, hands-on.
Sure.
I hate to use supervision, but it's medical direction.
Well, there are. I mean, I just, not to belabor this, but I don't think this act is intended to result in the independent practice of PAs. All PAs will still be required to have a practice plan with a supervising physician, and some of those, and that will be spelled out what exactly that means. But every PA will still be required to have a supervising physician, and I know that there are many PAs probably now who practice in surgical settings who probably have it clearly spelled out in their practice plans, and they will in the future as well, that the supervision for what they do is real time and immediate. So I just want to say, because I don't think that there's anything about this which is encouraging the independent practice of PAs. That's not what we're trying to do, or that's not what the legislator is trying to do, I should say.
Is there an alternative that you would recommend, Dr. Domino, with consistent that we could put in there to change? I don't like the language either, to be honest with you. And I hate denoting that we have to send a physician assistant to a certain type of training, an individual group of PAs that would have to go to a certain type of training, because then we might be saying, well, you're a neurosurgical PA, now you have to go do, you have to go take some special training, or an orthopedic surgeon PA or a dermatology PA, you have to have a certain amount of training. I don't want to specify a specific. I understand what you're saying though, and I do agree that especially with anesthesia, it's a very serious issue. Is there something though that we can get rid of consistent and use in that place? Is there a better wording?
I guess I think there is a program that these are folks who are trained and certified already, who work under the direct medical direction of an anesthesiologist. So my language was they must have completed an accredited anesthesiologist assistant program and passed the anesthesiologist assistant certification. That's my language. That does restrict people, whether that introduces some other things, but I do feel that the anesthesia training is very different. Again, I'm not a PA, but I do work with PAs in surgical areas and in other type of areas, and it's different.
Yeah, I would agree with that. I was a former respiratory therapist before I became a PA, and I looked into going into anesthesia as a physician assistant, and then realized I would have had to take the certified anesthesia assistant program. So I understand where you're coming from for sure. I'll be honest with you, when I read through the bill, I wasn't even sure why this got put in there. It just seems like one of those, oh, let's put this in about this. It doesn't make any sense to me in the context that we don't have anybody practicing like that in the state. So I do not object to the language that Dr. Domino recommends. Jim, if that's helpful, if you think that's too restrictive, we can, certainly discuss that too.
Well, no, I concur. When I saw this, I was a little. It seemed a little bit curious to me as well. Is it possible to see the WAPA language suggestion? Washington Academy of PAs.
Yes, and while we're doing that, we do have 2 more hands up, so I'm going to go ahead and let Chelsea speak.
Hi, good afternoon. My name is Chelsea Hager. I'm actually the contract lobbyist for the Washington Academy of Physician Assistants, so appreciate the opportunity to chime in here. With regard to a couple of comments that had been previously made, I just wanted to note some of the changes that were made in the law, since WAPA was the proponent of the legislation and well aware of some of the intent and the changes that were made throughout the process. So the law requires a PA delivering general anesthesia or intrathecal anesthesia to show evidence of adequate education and training in the delivery of that type of anesthesia. The supervisory role of the physician was further clarified in this law to say that physician assistants may practice in any area of medicine or surgery as long as the practice is not beyond the supervising physician's own scope of expertise and clinical practice and the practice agreement. The addition of clinical to that sentence as well as practice agreement. So we believe that there was a little bit of strengthening of that supervisory role, if you will. So we're understanding of the fact that PAs that might be providing these high levels of anesthesia should absolutely demonstrate that they have the training, but we're asking for the flexibility for that to be determined at the practice level. The question's been raised here today of whether or not this is actually happening. We're hoping to not put something in rule that's going to prohibit a practice that we don't have a lot of clarity on right now. So we would ask that we would not specify a specific type of training like a CRNA or an AA model, but instead require some sort of alternative rules or guidelines that we can look to ensure that adequate training is completed if this is going to proceed. And I believe Ariel mentioned earlier that this would be a big divergence from what is currently happening for any other PA, and it was not required by the law. So just would offer that for your consideration. And then we do have one other PA who's participating today who has one question with regard to the types of intrathecal anesthesia that are being discussed here, and whether or not we should have a discussion about exactly what that means as we proceed with the language. But I appreciate the time today.
Thank you. And we do have one other hand raised. So Linda, if you'd like to go ahead.
Thank you. I'm Linda Dale. I'm a physician assistant and represent WAPA, Washington Academy of Physician Assistants. And my question really is some clarification, because I can see PAs maybe delivering chemotherapy drugs through an intrathecal port as part of their practice with an oncologist. Is that going to be encompassed in this discussion about intrathecal anesthesia? The other thing is, it was mentioned, nerve block was mentioned, and someone mentioned it in an emergency room. Many family practice PAs do blocks for toes, to do toenail removal or to take care of an ingrown toenail. So I just want to make sure that we are very clear at what we're talking about here and not putting in barriers to PAs who are doing this every day. They may not be delivering general anesthesia, they may not be delivering intrathecal anesthesia, but they very well may be delivering medications in those routes for other necessary needs. I just don't want to put any barriers to practice or barriers to providing that care, particularly in rural and underserved areas. I know that the I-5 corridor has all kinds of practitioners, but you get out to some of the smaller sites, Benton City, Republic, Washington. We need to have PAs have the ability to do these things. They can do spinal taps to pull off spinal fluid, to check for meningitis. It's the same, the surgical type of sterile fields and those kinds of things all pertain to the same situation. So I just want to make sure we're not putting barriers, and I agree, no PA that I know of is doing general anesthesia, but that doesn't mean they won't in the future. And I think we have to be very deliberate and very specific about what we're talking about. Is it only anesthesia or is it all medications? Thank you.
I can say I was the one who mentioned that nerve blocks are not included in this because it's well recognized these are safely done with limited risk by PAs. As far as neuraxial, it's anesthesia. It's not just the whole issue is not just performing a spinal tap or an epidural. It's administering anesthetic drugs that may have different sequelae, and that takes additional training. So it doesn't cover any of the things you mentioned.
So with all of that said, do we have an idea of how we want to change this? If we want to include it at all?
I mean, do we have to include it because it's in the bill or it's in the law?
There's no requirement in the bill that we include language about the training. However, we've been advised by Heather it would be a good idea to have something in there in case there's ever a time when it comes up. I will say that, oh, sorry, go ahead, Heather.
No, I was just going to say, the bill talks about adequate training, and so the commission can define what it believes is adequate. So that was sort of where we were going.
Mm-hmm. So, and then Jimmy Bush has brought up another point, is that we aren't responsible for reviewing the education or the practice agreements. So if we implement some sort of education standards, then we have to have a way to enforce that standard, which I think was mentioned by someone else. And so these are just things we need to think about as we decide what we're going to say here about the kind of training they need to have.
That's why when you have someone who's graduated from an accredited program and is certified, that can take care of those educational standard reviews and not put it on the commission.
Amelia, yes, go ahead.
Excuse me. So there's a lot here right now. I mean, there's a lot. We have some really important input from a variety of our colleagues from other associations, and it seems like, I mean, I don't really see how we can sort this all out right now. That seems like there's a lot of thinking to do about this, and so I'm not really sure what the mechanism for that is. But it's hard. I mean, we have several different bodies of input and suggestions, which are not all consistent with each other. So I don't really see how we can really make a decision like this you know, right here and now. I mean, is that something that we need to do, or is it something that we can buy time? Or I'd like some input from you about that.
So we do need to make that decision today. However, we do have one other person with their hand up. And I'm sorry, Mark, for some reason it was there, then it went away. So I thought your question was answered. So go ahead.
Yes, my name is Mark Flannery. I'm a past president for the Washington State Society of Anesthesiologists and an immediate past alternate director representing the state society to the American Society of Anesthesiologists. I'd like to kind of echo a bit what Karen has stated in the term of the word consistent and what that should or shouldn't mean, or whether it should be in part of the context of this. But I didn't get a medical license to practice medicine in the state of Washington because I had training consistent with my preferred activities. I had to show my diploma from medical school, the fact that I passed medical boards, etc. I don't get to get anesthesiologist privileges at a hospital by passing the scrutiny of the credential department saying, yes, you're a board certified anesthesiologist. I didn't get that by being consistently present in residency training. I got that by completing residency training, passing the American Board of Anesthesiology exam, and then treating patients what I believe in a safe manner. The term consistent is vague. There should be something associated with a handwritten certificate saying that somebody's done more than on-the-job training of some background, or that they've taken a 1-month course in general anesthesia. There is no such animal that does that. The other point that I would make in terms of CMS is right now it basically is referring to whether an individual can bill their practices if they're practicing at a hospital or ASC that's licensed by Medicare. You can do whatever you want, period, in terms of CMS is my belief, but I don't believe you'll get paid for it. That doesn't apply where CMS isn't involved as part of the reimbursement profile, which would be consistent with office-based anesthesia profiles. The other question I would have is, what state is there that PAs can practice either independently or with supervision and deliver general anesthesia? I don't see that anywhere in the documentation other than reference to states are doing this, and that Washington State should be able to follow that example in some degree. Furthermore, as a representative, so to speak, of the American Society of Anesthesiologists in this case, as I'm looking at the statement from the PA Society, that it deems necessary to require specific skills of a physician assistant offering certain forms of anesthesia must possess, and the WAPA suggests that the Commission look at the American Society of Anesthesiologists for guidelines, recommendations, which generally state that physicians assistants should complete training for safe administration of sedative anesthesia for moderate sedation and benzodiazepines and other medications for deeper sedation. But the American Society does not have any endorsement of PAs giving general anesthesia or intrathecal anesthesia that I'm aware of. So that's basically, I guess, what I have to say at this point.
Thank you.
Thank you.
So yes, Jim, to answer your question, we do need to make that decision today. We are on a timeline as far as the bill goes. It's supposed to go into effect July 1. That's for other parts of the bill, frankly, but we are trying to move it along so that we meet, at least try to meet that timeline so that we are able to get these rules moving along. It's more associated with the medical commission, taking in the DOPAs. That's what those timelines are for. But, our goal today is to make this draft language what you want it to be so that we can pass it on to the policy committee tomorrow.
I wonder if my stupid computer keeps closing down on me in the middle of trying to read this. I'm wondering about putting in on the third line where it says intrathecal anesthesia has had training and certification. That is, I hate that is consistent. I agree. What else can we put in there? Would that cover it? And then get rid of, I don't know what else to put in there though, instead of that is consistent.
Why can't you say a certified anesthesiologist assistant program and past that the anesthesiologist assistant certification?
I like it.
I mean,
okay, can you say that
just specifies what it is. I just worried someone's going to take I hate to be this way, but seeing things that, studying anesthesia patient safety, there are issues. You could see someone coming in and taking a 6-month course and then they get a piece of paper. It says it's certified. I mean, you need a certification body, not just something that's not, that's all.
So Karen, can you repeat that one more time, what you think it should say?
Well, let me see so I would say instead of on the line 3, it says anesthesia, and then I would say must have completed an accredited anesthesiologist assistant program and passed or received received anesthesiologist assistant certification. Or you can say credit the program and received their certification. That just spells out, I mean, it's something that's already there that has all these, what the requirements are. And so we're not rediscovering the wheel, and we're not setting ourselves up for people who have entrepreneurs who are making programs that aren't adequate for decent training.
So Ariel and Mike, what do you think about this language? Is it fine?
Ariel?
Give me a chance to read it here. Yeah, like I said, this is going to be different for these PAs who generally have been only limited by the scope of practice of their MDs. They've also been limited by their delegation agreements, but I don't think that most, or if any, PAs have put education or training directly in their delegation or practice agreements. There certainly have not been requirements in the law or rules to have put that in here, so this will be different. I'd rather see it like this than a separate licensure or separate license. But this will be different.
Yes, Jim.
This is Heather. I just have one, just sort of not clerical change, but where it says it must be noted, blah, 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 anesthesia must have completed. I think replace must have with has.
This is Jim, and I almost think that it would be better to not have this anywhere in the bill or anywhere in the rules than to have it introducing a sort of a new concept in PA practice, at least in this state, where you have to have an additional certification to do something. I think that you know, as some of the comments we had from our public guests here, that's and also what Ariella had said before. I think that's for me a troubling precedent. I do understand also the concerns of the anesthesiologist among us, and who have both on the commission and from the public. So in some ways, I'm thinking that perhaps we should consider, rather than requiring a specific accreditation, that we should consider taking this out.
Well, Commissioner Anderson, I will say that the language of the bill is, if you don't put anything in here, it does require that something is said in a practice agreement for PAs who are delivering general anesthesia or intrathecal anesthesia. So that does have to be mentioned in the practice agreement. So if something isn't said in the rules, then it will be up to the PA and the supervising physician to determine what is adequate training or education. So
yeah, and that's very scary because that takes it out of any training or regulation. It leaves it up to individuals who may be entrepreneurial in this. And they may be doing it for financial reasons as well. I think it needs to be specified. It gives you, they have a set curriculum, they're accredited, they're recognized elsewhere. It gives a basic level of competence that you can assure. It doesn't say they're totally competent, but it says it gives them a basic level, as opposed to leaving it to a practice agreement where you don't know what's going to happen. I mean, you know, someone could be saying, oh, I work in the GI office, I'm doing sedation. I could give general anesthesia now because I did my moderate sedation course. That's, you know, I just really worry about it not being specified.
So Mark has his hand up again, so I'm going to unmute him real quick. Go ahead.
Yes, thank you. I'm sorry, I'm maybe sounding a little more angsty than I should, but could you bring up the document, the actual bill that you had highlighted in terms of the evidence of education and stuff? And I'd like to go over Ariel's point, is that the physician assistant, it already says in the legislation that it has to be addressed. And showing adequate evidence is also a bit ambiguous, almost like consistent. It's pretty much the same thing. So, James Anderson, I appreciate your thing about taking it out of the rules making, but it's really already there, being dictated by the legislation. And what I'm wanting to emphasize is that we're not trying, as anesthesiologists or anything, to be obstructive. But if it's going to go this direction, we want the public to be as safe as possible with the decision. It's a public safety thing. And to me, who, as I mentioned before, have gone through extensive training to get where I am, there's so many things and nuances about general anesthetic that you cannot just glean from a cursory exposure. And the other point with nerve blocks is I would agree that with Linda in that, you know, a lot of nerve blocks are pretty simple, but if you don't specify which ones possibly, you could have people moving into territories. For example, interscalene block is a needle that goes 2 or 3 inches into, or a couple inches into the depth of the neck to block nerves as they're coming off the cervical vertebrae. I mean, that in and of itself needs to be done with minimum anatomic knowledge, and ideally with ultrasound guidance to direct the needle to be effective. So, I mean, if you just say, this is, so I agree, this shouldn't be about nerve blocks at this time, but intrathecal, I don't think there should be any problem with the concept of taking anything out of the intrathecal space for analysis or review. But what you put in there, and chemotherapy is not anesthesia, but if you put in local anesthetics to the intrathecal space, there's a lot of physiologic permutations that could take place that would be hazardous if not known about by the practitioner to correct for and adjust as may be necessary for patient safety and during the block. And I'll quit with that.
Are there documents elsewhere that specify what PAs can and cannot do in the state of Washington? I recall, at least when I was coming out of PA school, seeing something like that from the commission, a summary of things that PAs could do and a summary of things that PAs generally could not do.
So
And I'm
you
wondering,
can actually see right here on the screen, and this is going to be the new law, but it has a good summary of what it is. It says the supervising physician and the physician assistant shall determine which procedures may be performed, and the supervision under which the procedure is performed. Physician assistants may practice in any area of medicine or surgery as long as the practice is not beyond the supervising physician's own scope of expertise in clinical practice and the practice agreement. There may be a little bit more up above that.
I
Physician
see. Yeah,
assistants may provide services that they are competent to perform based on their education, training, and experience, and that are consistent with their practice agreement.
Well, the reason that I'm still wondering why this particular practice is being called out in this rules version. I mean, there are many. Obviously, there are many other things done in medicine and surgery, which are extremely sensitive, high stakes procedures, and I don't fully understand why just anesthesiology had called out as needing to have this particular rule that you have to have this specific certification. I mean, because would we not agree that there are many practices in medicine that are similarly extremely sensitive and requiring the extremely high level of training and care, and I don't understand why just this anesthesiology is here. I don't fully understand that.
Yeah, I don't either, Jim. Ariel or Mike, or Heather, can we just take that third paragraph there? And I know that it's not, I really echo Mark's comments about adequate education and training as not being wonderful language, but can we just take that paragraph out of the law and stick that in the rule? Well, I mean, I know it's not as specific. I understand that, and I really understand Kieran's concerns and this, I think it was Amy, the CRNA, and I totally get that. But I'm kind of with Jim. I hate to put in, I mean, here it says adequate education and training, and leave it up to the anesthesiologist, who would be the precepting physician or supervising physician for the PA in taking care of this.
The law is operative. So what it says in the law, that is what people have to follow, effective July 1st. So you don't need to put it into the rule. People have to follow it. The rule, what we put into rule, is designed to enhance what is in the law and to use the authority that is given to us in the law and to go forth from that. So if you want that to stand on its own, you don't have to put anything more into the rules.
When you say if you want it to stand on its own, what do you mean by it? You mean the description above the underlined
That
paragraph?
subsection 3, if you didn't want to use your authority that comes from that, you don't have to do anything more. If you just want supervising physicians and PAs to put in a practice agreement evidence of adequate education and training, and you don't want the commission to define what that is, you wouldn't put anything in rule. The law, people still have to follow the law. Physicians and physician assistants still have to follow the law. The laws and rules work together. Physicians and physician assistants have to look at both the laws and the rules in order to determine what their responsibilities are.
And I certainly get the patient safety issue, you know, with somebody that doesn't have the training to be doing this. I mean, I don't know if you need a motion, and I don't know if we get enough an agreement, but I would make a motion to just throw out paragraph 3.
So
well,
we do have two. Go ahead, Ariel.
It's in the law. It's still the commission doesn't have the authority to not abide by subsection 3 or not have physicians or physician assistants abide by subsection 3 in the law. That it's
no, what I mean subsection 3 within the rule, Ariel.
Right.
So we do have 2 hands up. Linda, you can go ahead.
I just wanted to answer Commissioner Anderson's question about the list. Years ago, we used to have a laundry list of what we could do and couldn't do. And we worked within the Washington Commission and got that down to just what the supervising physician does within the practice, and then what the PA does is decided at the practice site. Because way back when that was first written, we didn't know what PAs could do and who they were and all that. And so we've removed that laundry list of what you were talking about. And again, you know, just to remind everyone that any PA that uses the anesthesia will be supervised by an anesthesiologist. And if we do what Commissioner Schimmel suggests, that still means that the PA who will be delivering any kind of anesthesia via general or intrathecal will still have to follow what their anesthesiologist supervising physician tells them to do. Thank you.
Well, Linda, I concur with concerns about the laundry list. And I wasn't bringing it up because I think we should go back to it. I was bringing it up because I think it's something that, I mean, someone could sit here now and create a list of 15 highly, extremely high risk procedures. And
correct.
But there's always 30 more. I mean,
right.
So I thank you for saying that, because I think it really is a more articulate way of getting at my concern as well. And I second Teresa's motion.
You know, and I will say that I disagree with the motion. I also disagree. I think, you know, in looking at my basic training in medical school and my internship and early part of my residency, before I went into anesthesiology, I had very little anesthesia training at all. You know, very, very limited things. I am really concerned when there is an effective program that's been shown to be safe and educates people well, to leave it up to individuals to pair off. Why hasn't this been done in other areas regarding PAs? I don't know. I suspect it may come in the future, to be honest, because really, can you really do, you know, addiction medicine without any training in that area? Training on site, you know. Some of the surgeon they spend a lot of years training in tutelage. Maybe they should have done some additional training as like a mini residency. So I think, to me, I just see it as one of the first areas where it has been carved out with particular training along with a model of the anesthesiologist's oversight to make it safe. I just am concerned leaving it up to individuals to make the decision of whether someone's adequately trained or not. And I say this because I study adverse outcomes in patients undergoing anesthesia care. And while they are rare, there are some that are really terrible. And our goal as part of the commission is to improve the safety of our patients in our state. And I think leaving it for free for all with anesthesia care is going to be against improving safety. It will make it much worse.
Yes, Amelia, are you letting me talk? I couldn't get the, thank you. I don't hear you.
Sorry.
Go
ahead.
I would just like to address a question, one to Ariel, in terms of just to confirm. What the law already says would allow the supervising physician, assuming it's an anesthesiologist, to determine whether the PA had adequate training under their supervision in the past to be certified, basically a self-certification process in terms of saying that he's agreed there's adequate evidence to this, to allow this PA to practice general anesthesia or intrathecal anesthesia. That's what the law says. Could you confirm that?
Right. If the commission decides to not go forward with any rules on this subject, then yes.
Okay. And then just one other clarification, maybe Chelsea from the PA could elucidate. What other state in the United States allows PAs or authorizes PAs to practice general anesthesia or intrathecal anesthesia? I'm curious to know that research.
Go ahead, Chelsea.
This is Chelsea. So I don't have a specific list that I can give you today. I could try and follow up with that. I think the question we should try to answer here, though, is are there any instances in Washington state where this has been an issue that we need to solve for? Or has the current status of the law that allows PAs to practice within the full scope of their supervising physician created the adequate patient safety that's at discussion right now? I don't know that there's an issue that we need to solve for. And so I guess I would submit for consideration again that, if there was a part on the practice agreement that allowed a PA to stipulate to exactly the training and education they have that leads their anesthesiologist who's supervising them to feel comfortable that has been acceptable over the course of the time that PAs have practiced in Washington state and should continue.
Thank you. And Amy, why don't you go ahead? Oh, she unraised her hand.
I raised my hand again instead of unmuting myself.
Okay.
So my question is, well, first of all, I would really like to hear from some of the folks who worked on the enacting legislation in 2020. I didn't represent the anesthesiologists then, but I would really like to hear what sort of the common understanding about this section of the law is. But if there's nothing in the rules that governs what the training should look like, then then it just says, adequate training and education. How will the commission measure that? Like how would it be determined whether someone was appropriately utilizing their practice agreement if the question about what the adequate training looks like is unanswered? I mean, so I guess that's a long way of saying I really think the rules should include specificity around what that training looks like, because otherwise I think you won't have consistency, and it's going to be well, I think it needs to be specific in the rules what the adequate training is, because the language in the legislation is pretty nebulous.
And this is Chelsea Hager. As we worked on the bill last year with the commission and specifically with Micah Matthews, this specific provision that ended up in the final bill was responsive to concerns that were raised by the nurse anesthetist. So they might want to share some details there about their interest in that specific language. But through conversation, we wanted to create flexibility for the commission, and so that's why the language is somewhat vague.
Thank you for that, Chelsea. So Melissa, you also have your hand raised. You can go ahead.
Thank you so much. So Chelsea's right. So I was working on this for the nurse anesthetist last session and working closely with Micah. So part of the reason that we addressed general anesthesia and intrathecal anesthesia separately is because of the change in the other parts of this bill, now law, that changed from the delegation agreement that was filed with the commission to a practice agreement that is no longer filed with the commission. And our concern that while we could never, and we asked several times, both WAPA and the commission to help us understand how many PAs are actually delivering general anesthesia to see if there is a problem. We could never get that information, and we asked if then we could just put a prohibition in the legislation saying PAs can't do general anesthesia, since it seems like we could never get a good answer about how many are actually doing it. And so this is the language we landed on. In my conversations with Micah, there was an understanding and agreement that this language, adequate evidence of adequate education and training, would be further defined by rule by this commission. So it's very disturbing to me that we're now faced with the commission not actually putting anything in this rule delineating what adequate education and training is.
Yeah, and I agree with that.
We
need to have
it's just not approved.
What did you say, Ariel?
The practice agreement is still filed with the commission. It's just not approved by the commission.
This is Teresa. I'd like to, first of all, withdraw my motion, but I've been doing a little bit of research while I've been listening, and I am finding that in just a, certainly not a broad review over just the last few minutes, but in review that I did a month or so ago after some questions about this, and then again today, it looks like any PA that has practiced or is practicing as an anesthesiology is either a prior CRNA or anesthesia assistant, already certified in doing that, in looking at what I have been able to find. So I would go back to the language, if you could pull that up, Amelia, that we put in with Karen's, Dr. Domino's advice, and discussing the language issues that folks were just talking about that were going to be put into the rules. And let's come up with some language. Let's hash this out, so we have some kind of language in there that is acceptable to everyone.
Well, you could add nurse anesthetist, certified nurse anesthetist training, although I couldn't understand why a nurse anesthetist would want to become an anesthesia assistant. But
I don't think that needs to happen. I think what we've got there with the accredited anesthesiology assistant, I think that's plenty. I wouldn't want to add anything else back in there again, but does anybody want to change this? Sorry, Jim, I'm kind of jumping in for you as the chair. But let's hash this out. If we need to put something in there, we're going to have to come to agreement with it, and we don't have a ton of time to be able to continue on this. There's obviously issues on both sides. I understand Linda and Chelsea's position. I have my own worry about asking us to have another type of training, specific training. We don't have that in any other area. And I was actually part of the rules where we took out those old practice guidelines, Linda, way back when. I think you probably helped work on that as well. But we've got to come up with something, and we need it to be something that's going to keep patients safe. That's what the commission is about, and that's what these rules need to be about.
Teresa, no, I don't feel, I welcome your input. Thank you. And I don't feel as though you're taking over my exalted role. So no problem. So I would just, I think we're all, some of us are kind of restating our position here, and I think that's understandable, but I'm not sure we need to do that. I'm still not comfortable with this, and I think someone asked a question a little bit ago about how would the commission review a case of a PA doing general or intrathecal anesthesia, whatever concerns, and I think the answer is the same way that the commission currently reviews some of the extremely complicated, highly medical practice that requires a great deal of training and a great deal of competence. I mean, that's what the commission does. Commission does now, and we do it through the. I think what's good is we do it through the use of experts. We do it with excellent legal staff. We do it with collaboration. That's how we do it now, and we don't. And I think even if the words required a certification were not here, that's how we would continue to function and deal with questionable practice. Period.
So with all that being said, do we need to make any changes to this language? I realize, Jim, you said you still have some issues with it, but I mean, what's the consensus here? We would like to move on from this particular section, but I want you all to be comfortable with it.
Well, I don't think there is consensus, but just frankly, there doesn't really have to be consensus, right, for us to move forward. I mean, how would a board such as this typically make a decision when there's not consensus?
So you as a panel have to agree on this language by majority. There's 4 of you, so.
Yeah, so there's room for there to not be consensus, correct?
Mm-hmm.
Yeah.
For sure. So if you don't agree, then I mean, we can't move this forward without figuring out what we need to do with this particular section of the bill.
Well, what if we just, if there's 4 of us who will be, there needs to be 3 of the 4 who think this language should be in there, and if there are 3 of the 4, then the issue is done and we'll move forward, right?
Mm-hmm.
Yeah. So why don't we see if there's 3 of 4, and if there are, great. If not, then we got to figure something else out.
Before we move on, can we get some clarification on this language? The received certification part, is it certification in the program? Is it certification as an anesthesiologist assistant?
Could we just say in the program?
Does that mean anesthesiologist assistant certification? They have a certification there. It comes through. Where is this? I don't know where it is. They have that body that oversees all of them. Commission on Accreditation of Allied Health programs, and they provide their own certification. So I don't know the exact term you want there, but you don't want someone who just went to the program. You want them to have passed and received a certification from the program, right? It's like going to medical school and receiving your MD.
So we're looking for someone who's received certification as an anesthesiologist assistant.
Yeah.
That's
yeah,
what I
or
think.
yeah, it's certification. Yeah, I think it should just be a little bit clearer. Sorry, just want to make sure before we took a vote that the language was. Mike, did you have any comments about the language?
No, I had comments about the process and about,
Okay.
are we really required to have a decision today, or can you bring this issue? It seems to me like this is an issue for the larger commission, and there's opportunities in the process for the commission to choose which way to go, or even to change its mind as we go through the process. It's really at the 102 process that you need language, if I'm not mistaken, Amelia and Heather.
So, but the problem is that if we don't have some kind of language on this or a decision on this particular item, I'm not sure that we can ask the commission to move forward with the 102, because by the time we get to that point, we should have language that they all like.
Yeah, I'm saying with that there's opportunities before we get to the 102. There's going to be a discussion first at the policy committee meeting, and then before the commission at business meeting, and that's when this discussion can come up, and we're going to have to put aside some time to have an adequate discussion, because every commission member is going to have to weigh in on this. And it's that time when they vote to go forward with the 102, it's then that they decide, okay, you need to be certified, or we're not going to have this language at all, or something in between. It doesn't need to be decided today.
Right, but we do need to provide them with something from the panel so that they know what the panel's intention was. So,
well, I think you can provide 2 options or 3 options. Say the panel agrees on every word in this draft except for this issue. I don't think we need to force a decision today. That's all I'm saying. Just consider not forcing a decision today, but holding off on this issue until it hits the whole commission.
I agree with that as well. I think it's a good idea to wait, because it's not something that 4 people should be making this decision, really.
Well, they are the ones that make the decision. Ultimately, it's just that we have to, this panel has to make the decision whether they're going to recommend moving to the 102 to policy tomorrow. Then policy can have their discussion about any issues they have in the language, and we can certainly bring up the fact that this language is not totally great, that you guys decided you know, we're just moving forward with it. We want to get some input from policy. Sure, we can do that, but we need to provide them some idea of either whether you as a panel want to have something in there or not, or have this language, or get their feedback.
This is Heather. My recommendation would be to, it sounds like at least a couple of the members of the committee like this language or something like it. I would say you move forward, you vote to move this to policy with the caveat that we approve all the language except where there is some still disagreement over sort of the, not just wording, but the policy of what sort of training is going to be required. And I think if you get a bigger group, the policy committee can then make that decision, and it should be quick to make a little revision if we need to.
Has Dr. Chung weighed in? Is he here?
Yeah, I did ask a question earlier.
Yeah, what do you think about? I'm interested in your input.
Well, the question that I had asked earlier was that I'm not familiar with anesthesia assistants. I mean, I know they exist, but I've never seen one in practice doing what we've described here, delivering general anesthesia. And so I'm having a hard time trying to imagine what this would look like. I think in principle, I think if you're going to be doing general anesthesia, you're either going to be a general anesthesia or an anesthesiologist, MDDO, or a CRNA. And I'm even questioning, do we know enough about anesthesiologist assistant programs that even receiving a certification from one, qualifies you to deliver general anesthesia in a setting where, an anesthesiologist might not be like right at your elbow. So maybe that's a question that someone can answer for us.
Well, I do know they've been around since a long time, meaning at least 20 years. I saw here, in 1998, they were required to require graduate level of education. They generally require pre-medical curriculum, which I assume is similar to PAs. And so they have a basic core of pre-medical sciences. They then get a Master of Science degree with it, and they have a type of about the clinical training. If you compare to a CRNA, is similar in terms of number of cases. It's at least 2 years, usually 3 years. I think we heard there are 17 states that offer these. There are at least 13 or 14 academic programs, since they have to go through a medical school in a lot of states. So like Colorado, Florida are some states that I know that Wisconsin have these programs, and their academic medical centers that train them. So they are well respected within the field of anesthesiology. The ASA has well respected them too. They work under the direct medical direction of an anesthesiologist. They also don't earn as much money as a CRNA or an anesthesiologist. And so some groups are interested in this option because of that. They can actually, as reimbursements go down, I think there's some interest in that on a national level. So from my understanding of people who work with these folks, is they're well trained. They are not nurse anesthetists in the sense of having the nursing background, but they have a good background in science and in anesthesia, and work, again, under direct supervision, medical direction.
Right. So I think that was the key point that I was asking for clarification.
Yeah. I mean, we could provide information on. Yeah.
Yeah, because CRNAs can practice in many states through the, through having their governor opt out of the program. But so that's legal. Again, if they're practicing anesthesia under direct supervision, I guess it seems like it's a different kind of situation. But again, I'm not sure if what it would look like if they were actually practicing, let's say, in one room, and the anesthesiologist who's supervising them is in another room, and what that kind of agreement looks like. So I guess I'm just not familiar with that scenario. I mean, I've worked with plenty of CRNAs. I mean, that's so I understand them completely.
So can we take this to the policy committee and say, at least as of now, that we are in agreement, although we're sort of stuck on this particular item, and that, as we've discussed, there are sort of three options. One is to take it out, one is to leave it in like the original wording, and one is to leave it is to move forward with the certification of language, which is in there right now. Is there a way for us to technically to do that? I mean, can we could we all just agree that, great, let's bring these issues up to our colleagues in the commission and see what they have to say.
Does there have to be a motion
I
for
just
that,
say
or can we just do
the
that?
WANA also has something that specifies a bit more than what the original language was. And that specifies the type of the training. So without mentioning anesthesia assistant certification and all that, but no other PA would ever have the sort of training that a certified nurse anesthetist or a physician anesthesiologist would have.
So
yes,
would we make a motion?
A motion because
we can just agree that that's what we're going to do. Okay.
And then we just need to go through some other parts of this language before we adjourn.
I think that would be great. It would be a vast relief for me for us all to have to vote on this right now. I'm being told I have to exit my building shortly, so I need to just step out for a moment and negotiate that. So I'll be right back. In my absence, I assume that somehow, some way, this meeting will continue to function until I get back shortly. Okay, thank you.
See you in a minute, Jim. Okay, Amelia, what's next?
So there's just a note at the top that there's some changes that will be taking effect July 1st of next year. So we're going to do expedited rulemaking next year to deal with those issues. And then all this other language has been dealt with except for, hold on, I'm going to pause my screen because the scrolling is crazy. So there's one more thing in practice agreements that we have to talk about that was brought up by a commenter. So in the bill, it talks about that a physician may supervise no more than 10 physician assistants. And I have that language over here on the right from the bill. So I re-added, which it won't be subsection 7, it'll be section 4. I re-added this and then just changed it enough that it would meet what was in the bill. So we're just changing 5 to 10 and that they can submit a waiver. And then we're still including that no physician may have under his or her supervision more PAs than the physician can adequately supervise.
And I would get rid of the word but and change that and may petition.
Okay. Okay.
What section is this?
So this is the practice agreement section. It was subsection 7 of that one. So it's the one we've been looking at. It's 918055. So this was just added today because I got the comment about it yesterday, I think.
Is this putting is this language the exact same as the statute?
No, it's over here. The statute is over here on the right where it says from the bill. That's what it says.
So no more than 10, up to 10.
Do we need to change it to no more than instead of up to?
So I'm just trying to see what the purpose of us putting the same exact, like if it's the same language in statute, why we would need it in rule. But we took out a lot of the language in the rule because it got put in statute. So unless there's more language or different language in the rule, there's not really a reason to also put it in the rule.
And I'm fine to remove it. We just got this comment, so I was just trying to incorporate it in here.
So I'm not seeing any difference. There's not, so unless someone wants to comment with, if the person's here who wanted us to add this language, there's not any reason to have language in 2 different places, and it increases the risk of error when we make changes in the future. And as you can see, this isn't the exact, it's not the exact same language. So where we have language in 2 different places that's not the exact same, it can be confusing about which language we should use. So it's best to just stick with the language in one place.
Okay. Chelsea, you have your hand raised. You can go ahead.
I do, and that comment actually came from WAPA. I'm comfortable with that language not being spelled out in rule, especially since one of the changes that was added to the law was that you're essentially grandfathered in if you have already received a waiver from the commission to supervise more than 10, and that wasn't in the rule. So I'm happy to take that out.
All right. Moving on. I'm going to pause my screen again. So I think that was the only other item that we needed to discuss. Yeah, we talked about that. I think that was the only other piece that we needed to talk about. Oh, there's one more place. Hold on. So section 126, which is about non-surgical medical cosmetic procedures, we define in 3B, we define physician and physician assistant there, but obviously we define those elsewhere, so I'm not sure if we need them there again.
Sorry, can you bring that up on the screen?
It should be loading. There it goes.
Oh, I wonder why it's in there again.
Mike says thumbs down.
Because when we adopt rules, we always stick that in, and then when we look at the whole thing, we realize we've defined PA and physician about 18 times.
And we're trying to get away from
Agreed.
that.
Blow it out of there.
Okay.
Take it out. I agree, Mike.
That's easy enough. Let me pause again.
Are you gonna have to re-letter those? Yeah.
Yeah.
Now we're rolling.
Yeah, hold on. I don't think. I don't think there's anything else, but let me make sure before we adjourn. Okay, that is it because the only thing left is the opioid prescribing and we are not touching those.
So that brings us to the conclusion. Anyone else who wishes to comment?
So there was one more in the questions. Let me see if I can get this whole thing up here. They said, it would seem the guidelines of the American Academy of Anesthesiology Assistants would matter here as far as certification under title of anesthesiology assistant is concerned. Their website specifically states, likewise, a PA may not identify him or herself as a CAA unless he or she has completed an accredited AA program and passed the National Commission for the Certification of Anesthesiologist Assistants exam. If also certified as a CAA, such a dual credentialed PA would be required to practice as an anesthetist, only as an extender for an anesthesiologist and could not provide anesthesia care at the direction of a physician or any other specialty. And then the commenter states, that would seem incongruous with any language today that could be perceived as stating otherwise as far as certification is concerned. And then they made another comment, or lack of language, I should have also said. That's the only other comment we've received. Chelsea has her hand up again though, maybe? Or is that left over? It's left over. So we have no other hands raised.
So, Ms. Boyd, do you have anything to say about discussing timeline and next steps?
Let me pull up my little presentation and get it rolling. Okay. All right, so the timeline, let me get my other piece of my presentation working here. Okay. So obviously, like Jim mentioned in his script, we did file the 101 in November. This is hopefully the end of our stakeholder work. We plan to, from what I'm hearing from this workshop, we plan to provide this new draft language to the policy committee tomorrow. And then based on whatever recommendation they have, it may be presented also to the full commission on Friday at their business meeting. And then if they approve the next step, which is the CR 102, then we will move forward with the formal proposal. And then our public hearing would be scheduled. If that happens, our public hearing should be scheduled sometime in August. And then the final rule adoption would happen around September. And then the rules would be in effect in late 2021. And so, like I mentioned, we will bring this new draft language tomorrow and the next day. And then, as I mentioned, we should have that hearing in August of 2021. And then if you need to contact me, here is all the information. And then if you have any questions, you can reach out to me directly. And my email address is amelia.boyd@wmc.wa.gov. And that is all I have.
Very good. It's been a scintillating time with it. I appreciate all the comments, and it's been great to get the input and have the discussion that we had. So I really appreciate everybody and how you've all contributed to this. And so if no one else wishes to speak, I will close the workshop now. And thank you very much. Have a good evening.
Thank you all.